Great. Good evening, everybody. Welcome to Together Facing Prostate Cancer. I would like to thank our patients, our caregivers, our advocates, and guests for joining us this evening. I'm Dan Geinesman. I am a genitourinary medical oncologist here at Fox Chase, and joined by some of my great colleagues and faculty here as well. Tonight, we are going to try to share a little bit about some research that we're doing here at Fox Chase, a little bit about some advances in prostate cancer, and then also hopefully answer a lot of your questions that you may have. Typically, of course, we can gather for this in person. Wish we could do that, but obviously given COVID and what's happening, we cannot. So this is a great means to connect and hopefully in the future can see you guys again in person. If you have any questions at any time, please leave it in the chat feature on Facebook, and we're going to try to do our best to answer all of them. Before we continue, I'd like to take a moment to honor those we have lost to cancer, and so I'd just like to ask you to join me for a moment of silence. Good. Thank you very much. I also want to thank our exhibitors. They've been very generous, and it's because of that we can really offer these kind of programs. And special thanks to our gold exhibitors, Caris and Tempus, and our silver exhibitors, Avea Oncology, Bristol Myers Squibb, Foundation Medicine, Guardant Health, Janssen, and Sanofi Genzyme. And I would like sort of to briefly introduce our panelists and then really go one by one and have them all talk for 4 to 5 minutes about what they do, their area of interest, maybe some research, or some of the new things that are happening here at Fox Chase. So Dr. Mark Hallman is a radiation oncologist. Dr. Leah Viterbo is a urologic oncologist, and sitting right next to her is Trish O'Brien, who's our wonderful navigator, one of our GU navigators. We have Holly Riggs, who is our GU social worker. We have Dr. Karen Wong, who is also a radiation oncologist. Next to her is Dr. Correa, urologic oncologist. And again, my name is Dan Geinesman. So why don't we start with Trish? And she maybe will talk to us a little bit about what she does and about navigation here at Fox Chase.
Hi, everyone. As Dr. Geinesman mentioned, my name is Trish O'Brien, and I am one of the urology nurse navigators here at Fox Chase Cancer Center. I just wanted to touch briefly a little bit about navigation, and then I'll go into the process. So our navigation department was one of the first in the region and is based on disease sites like urology, so that we're focused on specific types of cancers, and work closely with the various providers as part of the team approach that we have here at Fox Chase Cancer Center. So the navigation process begins. So the first step would be to call into our new patient office. They'll ask you for your basic demographic information and enter the information into our system. This includes your insurance information. So the phone number for the new patient office, and we can also provide this also at a later time, but is 215-728-2570. You can also do this in an online request, which is located on our foxchase.org website. After you complete the online request, someone from our new patient office will call you again to go over the basic information, your insurance information. A message is then sent to the appropriate navigation team. So for example, prostate would be sent to myself and my colleagues. GI or colon would be sent to the GI navigators. Our financial counselors will then review your insurance information to ensure that your insurance is accepted at Fox Chase. And then we will call you once your insurance is approved. At that time, we will discuss with you in detail about your diagnosis and what testing and treatment, if applicable, you've had done so far. It may sound like a lot of information that we're going to ask of you, but the better prepared our physicians are, they'll be able to give you a better plan of care. So we will then discuss with you the physicians that you would like to and or need to see here and schedule the appropriate appointments for you. We will work with you to get your medical records sent to us prior to your appointment. And this includes any imaging that you may have had done and any slides from any prior, surgeries or biopsies that you may have had done. And we understand that it is an overwhelming and difficult time for our patients. And as you'll see in the next presentations, we are all here to help you along this journey.
Great. Yeah. Thank you, Tricia. I mean, it's immensely helpful to have you guys do that because it just makes for a much smoother, I think, appointment, much better consultation. And I think patients oftentimes mention how much support they received from you and your colleagues. So it's really, we're privileged to have that. That's great. Let's move on. Dr. Correa, maybe you could introduce yourself, tell us a little bit about what you do, and maybe discuss a little bit about some new technology that you guys are using to diagnose prostate cancer.
Yeah, thank you, Dan, and thank you for inviting me to this program. My name is Andres Correa. I'm one of the urologists here at the Cancer Center. I want to thank Tricia Bryan and her team for everything they do. They really are kind of the first stepping stone in this process, and patients really, really appreciate the work that they do. So thank you for everything you do. So I'm a urologist. So our job here at the Cancer Center runs from talking to the patient to see if they do have a risk of having prostate cancer, to go into getting that cancer diagnosed, and to maybe then discussing some treatment options for people that have localized disease. When it comes to prostate cancer, a lot of the consults we get is patients that are very, very concerned about their PSA being elevated and what that means to them, because there's so much confusion when it comes about what the PSA actually means. And our job here is to be able to get all that data and be able to educate the patient and what this PSA actually means, and how can we actually better treat them or manage them based on their physical exam and some imaging technology. So a lot of people probably in the channel can tell, is that MRI has brought us closer to be able to better guide patients to biopsy than before. A lot of patients were getting biopsy just based on PSA results, and now we're using imaging, like in other cancers, to be able to guide that process. The problem with MRI is that MRI is not for everybody. Going to an MRI machine is not a comfortable event for anybody, and a lot of patients cannot do that. And others just cannot do it just because they have pacemakers or that metal in your body, and they just cannot go through the process. Fox Chase has been fortunate enough to be donated a micro-ultrasound machine, which kind of merges the ultrasound technology with what the MRI is able to find, and this has been revolutionary for our patients. The reason for that is because now we can use an ultrasound where the patient really doesn't need to go through a machine to be able to diagnose these lesions just like an MRI will do. And that has helped tremendously to get patients that either don't want or cannot get an MRI, or where MRI is really not detecting the lesions that we need to find. The micro-ultrasound can sometimes identify those lesions and get the patients a prostate cancer diagnosis, or in those in surveillance, identify that lesion that might be a more aggressive prostate cancer they can proceed for treatment. So again, very fortunate to work here, and I really appreciate all the support I get from the navigation team as well for the colleagues that work with me.
Great. Yeah, thank you. And again, I'll remind folks, if you have questions about anything that anybody's talking about, feel free to put that in the chat function, and we'll try to kind of address that and hone in on that in the Q&A session. And then Dr. Viterbo, another one of our urologic oncologists, maybe you can talk a little bit about, when you do your point of view on prostate cancer, and maybe how you use some of this technology in surgical planning.
Thanks, Dan. Again, thanks to everyone here tonight. Special thanks to our nurse navigators, our social worker, and all our exhibitors for your support. I am very grateful to be here. And as Dr. Correa said, very grateful for some of the donations that we've had to allow us to get an exact view ultrasound. And, with the pandemic Sometimes we see patients who have a lot of anxiety regarding prostate cancer. As a urologist, I treat all kinds of urologic cancers, but specifically we see patients with prostate cancers. And we're fortunate enough to sometimes go through the process of diagnosing that prostate cancer and having special technology, like Dr. Correa said, an exact view ultrasound, which accommodates people who may not be able to get an MRI or maybe have some insurance issues and cannot be afforded an MRI. And this is something that we can do for our patients. And then in going one step further, some of these patients who are diagnosed with prostate cancer may be a little bit more advanced or may find that may need different treatment options. And it's exciting to have this technology to be able to gauge, well, where is my prostate cancer? Is it confined within my prostate? Is it locally advanced? And then to maybe discuss what treatment options are available. That may change depending on what stage of prostate cancer you are, whether the disease is confined within the prostate, or whether the disease is locally advanced just outside the prostate, or maybe in some instances, maybe metastatic and may have to offer the patient different treatment options. So this technology can not only help us during diagnosis, but can help us, kind of delineate what treatment options you have. And even at the time of surgery, may help us maybe carry out some nerve sparing, which can translate to better quality of life, erection recovery, and continence return. And this way we, decrease the potential risks and complications of surgery, and are able to do this robotically with magnification that allows better nerve sparing and better continence control and outcomes as well. So, again, these are some great advances in cancer, and again, grateful to being able to take care of patients both with local or even advanced prostate cancer, as some of our colleagues will discuss tonight. Thanks, Dan, for the opportunity.
Great. Yeah. Thank you. Thanks a lot. Moving from surgery to radiation oncology, Dr. Holman is here, one of our GU radiation oncologists. So would you like to say hi and talk a little bit about radiation for prostate cancer?
Sure, I'd love to. Thank you very much for the opportunity, to everybody for sponsoring this event tonight. Thank you to our patients for attending this, and thank you for having. It's such a privilege to work with my excellent colleagues on all phases of taking our patients through their cancer journey. I'm a radiation oncologist. We get involved in many different, from early stage cancers on up to metastatic cancers. I'm going to talk with you a little bit about short courses of radiation therapy that we can offer for localized prostate cancers. We've helped pioneer these types of treatments here at Fox Chase, not only with short courses with external beam, but we also have a lot of experience in a large program using HDR brachytherapy or high dose rate brachytherapy. Most people are familiar with radiation therapy for prostate cancer, where we use high energy X-rays to kill cancer cells in the body, obviously focusing that on the prostate. But high dose rate brachytherapy, or brachytherapy in general, is a way to deliver radiation using an implant of a radioactive source. We favor high dose rate brachytherapy because it's a technique where we don't have to permanently implant that radioactive source in the prostate. The procedure itself is a minimally invasive procedure. It's very similar to the biopsies that men have to diagnose the prostate cancer. It's done under ultrasound guidance, transrectal ultrasound guidance. And we use needles that go through the skin into the prostate, and this is our avenue to introduce the radioactive source into the prostate. It's done under general anesthesia, so patients are asleep during the procedure. Not every patient is a candidate for brachytherapy. So a lot of where we use it often is for patients that have more favorable intermediate risk prostate cancer. In those patients, it can be used alone. In that case, it's a very nice and convenient treatment because it's typically 2 procedures that are about a week apart. We split the radiation dose into basically 2 halves. And we deliver half of the radiation 1 week, and the patient comes back for the same procedure where we deliver half the radiation the next week. It is an outpatient same-day surgery procedure, so patients don't need to be admitted to the hospital for this. It takes about half a day. The procedure itself takes 2 to 3 hours, but you're here for about half a day for recovery and things of that nature. Patients like it because it has similar side effects to the other radiation treatments, and it's probably one of the shortest treatments that we can offer. From a radiation's perspective, I think it's nice because it's the most accurate way to deliver radiation therapy. External beam radiation therapy or X-ray radiation therapy does have to pass through the tissues, and this has an advantage that since the radiation is delivered right to the prostate, you receive less radiation to the bladder and the rectum. So it opens up this treatment to patients that have had prior radiation for things like rectal cancer or bladder cancer, things where we have more issues with external beam radiation therapy. We can also use this in high-risk prostate cancer patients. We can't use it as itself as a treatment, but we have good evidence and prospective and retrospective studies, clinical trials, and data that we've collected from patients that have been treated historically that show if we combine external beam radiation therapy plus one of these implants, it's one of the most successful treatments that we can offer for high-risk prostate cancer patients. So it's a very strong program. We do a lot of these procedures here at Fox Chase. I did one this morning. We have several, Dr. Wong and one of our other colleagues, Dr. Horowitz. We all do these procedures. So it's something we have a great deal of experience and expertise. And we do a lot of research in terms of how patients tolerate this and where it's best used and what patient outcomes are. So I think that's probably as much as I have time to discuss, and I look forward to your questions and our other panelists' discussion.
Great. Yeah. Thank you, Dr. Hallman. There's a lot more that I'm sure all of us can talk about, and hopefully some of that will come out in the question and answer part. Dr. Wong, love to you introduce yourself and then talk a little bit about radiation for maybe a little bit more advanced prostate cancer, and maybe a little bit about some of the research you're doing.
Great. My name is Karen Wong. I'm one of the genitourinary radiation oncologists, along with Dr. Hallman and Dr. Horowitz, our chair. I specialize in prostate cancer, and one of the areas that I'm particularly interested in is the developing oligometastatic state for prostate cancer. Traditionally, thinking was divided into two camps. You either had localized disease that was just in the prostate and you were treated with curative intent therapy, or you were found to have widespread metastatic disease and treatment was mainly based on hormone therapy or other systemic therapies with little role for local therapy. There's been this developing area of research that we've now recognized this oligometastatic state, where there may be spread to a couple of other locations, but not necessarily everywhere throughout the body. So patients in this intermediate state can benefit from local therapy to every area of disease and be treated with potentially curative intent. And one of the ways of treating in this particular case is with stereotactic body radiation therapy, or SBRT, or if you've ever heard the brand name Cyberknife. That is a modern radiation technique, which is using different types of radiation planning and anywhere from 50 to 100 different beams of different sizes, shapes, and intensities that are all used to concentrate radiation in very small areas where you can get a high ablative dose of radiation that falls off quickly and doesn't cause as much damage to normal tissues around. So we can treat with pinpoint accuracy to very small areas without causing any destruction to normal tissues beyond a very small radius. This is a non-invasive sort of treatment, and it shortens treatment times and giving a full ablative radiation course in something like 5 treatments or less. So the less of you that gets radiated, the less side effects there are. And as long as these targets are in favorable locations, it's a very safe and effective treatment. Not only does radiation have very ablative local effects, it can also have systemic effects. And one of those is it can be radiation's effect on the immune system. Prostate cancer has typically been thought to be more of an immune cold cancer. So different advances in immunotherapy that we've seen maybe in other cancer types have been slower to come to prostate cancer. Radiation can increase the immune reaction. Even local treatment with radiation can upregulate systemic immune markers, and really getting a better picture of the interaction of these can help us design the best combination of treatments for patients in the future. So I actually have a protocol in development that is a translational study. I'm a translational scientist. I come from a science background that can really be done as a bench to bedside sort of project, looking at patients that are actually getting this stereotactic body radiation therapy as they would otherwise for their disease, but also in the meantime, looking at how that treatment affects immune responses and being able to fully and comprehensively characterize the immune response to this sort of a treatment to better tailor therapies in the future and hopefully come up with new combinations of treatment to make immunotherapy more effective for prostate cancer.
I am still muted. There we go. Thank you. I was going to say thanks a lot. It's exciting research, and immunotherapy is everywhere in the news, of course, especially for cancer. So prostate cancer has been challenging, as you mentioned. So it's really important work. As I said earlier, represent the medical oncologists. There are actually 5 of us here at Fox Chase: Dr. Plimeg, Dr. Zibelman, Dr. Anari, Dr. Gatali, and myself. And all 5 of us see really all GU malignancies, including, of course, prostate cancer. And I think if you're a patient, you may meet us for various reasons. So, for example, you may meet a medical oncologist here if you're getting radiation and you need hormone therapy along with that radiation. We may be helping then. You may meet us if you've had radiation already, or if you've had surgery, but for some reason your PSA starts to rise. Something we call, for example, biochemical recurrence or biochemically recurrent prostate cancer. And then, of course, you would meet us if, unfortunately, you have metastatic prostate cancer or advanced prostate cancer. And certainly, by definition, medical oncologists tend to focus on that. There has been a tremendous amount of progress, I would say, in prostate cancer in the last 5 to 10 years, where just about a decade ago, really all that there was androgen deprivation therapy and a single chemotherapy drug called docetaxel, to now where there are multiple oral hormonal medications. There is a vaccine. There are targeted medication based on mutations. There are more chemotherapies. There are radiopharmaceuticals. And of course, lots of new promising drugs in clinical trials. And one of the things that we certainly try to do is bring the latest clinical trials to our patients. For example, trying to push forward this immunotherapy concept, we have immunotherapy type drugs targeting PSMA, which is a sort of very exciting marker in prostate cancer and a target in prostate cancer. We have radiopharmaceutical therapies against PSMA as well. We try to bring novel sort of small molecules that are being combined with hormonal therapies, and trying to integrate also novel imaging modalities. I know there are questions already coming in about PSMA, for example, imaging, trying to see if that can be employed as well. So we work really closely with the urologic oncologists, with the surgeons, with the radiation oncologists. It's really a team approach. A lot of times there's a back and forth. So you heard, Dr. Wong talking about radiation, for example, for oligometastatic disease. That is oftentimes done in conjunction with systemic therapy. And sometimes you do systemic therapy and then you do local therapy and you go back and forth. Sometimes you bring in cryotherapy, for example. So it's really kind of an integrative approach. We have a wonderful team here. It's an honor to work with everybody. And I will pass the microphone, so to speak, on to Holly Riggs, our social worker.
Hi, thank you. My name is Holly Riggs. I am the social worker that works with the prostate cancer patients here at Fox Chase Cancer Center. And my job is to support your mental and emotional health while the doctors are worrying about taking care of your physical health. We do that in a number of different ways, and there is a whole team here at Fox Chase who's available to you to help. We offer individual counseling for both patients and family members to try and help you deal with the emotional impact of cancer. We also offer support groups that help patients and families connect with other people who are going through similar circumstances so that you can feel the support of other patients. We have a whole psychiatry team that helps us address deeper depression and anxiety issues through medication. They also do cognitive behavioral therapy and things like that. So we coordinate with them to try and help make sure that patients and family members are feeling supported in all aspects. I want to mention specifically our prostate cancer support group, which meets the second Thursday of each month from 6:30 to 7:45. I think they're going to put a link up on Facebook for us. That support group currently is meeting totally virtually via Zoom, but it is up and running. And if you are interested in participating, you can either call the urology office at 215-728-1111, or you can call my office at 215-728-2936, and we'll be more than happy to try and help you get set up with that group. It's been very successful, and they do sort of a combination of psychoeducational as well as an opportunity to talk to other people.
Great. Yeah. And, there's also a whole supportive oncology and palliative care group here, which is also important, along really a whole continuum of care, and can really be helpful with pain management and psychosocial support as well. And there's also a very strong genetic group here. So genetics have really come to the forefront in prostate cancer. It's something that we often test for, we look at. Treatments sometimes vary based on that. And this is something also that we should all be thinking about, and we have here at Fox Chase. So I think, and this is good, we're a little bit ahead of schedule, which leaves more time for questions, but let's open it up to the audience, right? We have some questions that have already come in, and if you have any questions, put it in the chat box. We'll try to get to that, and even if we can't do it while we talk, we can always try to get back to you later on. So let me start off by asking kind of a very general question and putting maybe Dr. Hallman here a little bit on the spot. But, if I have prostate cancer, and I have localized prostate cancer, there's radiation, there's surgery. How do I make that decision? It seems honestly complicated. There's a lot of different techniques. How do you counsel your patients about that? What are some important things to consider?
Well, so thank you, Dan. That's a great question. I think it is complex, right? And it's probably something that I can't just give you an answer for. I think a lot of it has to do with patient preference. One of the things I really enjoy about Fox Chase is that we work as a team. And so, for example, if I have a patient that comes to see me and talk about radiation therapy, and they've not yet seen one of our urologic oncologists or surgeons that treat prostate cancer to discuss radical prostatectomy or surgery to remove the prostate for curative treatment of prostate cancer, then I would refer to them to that. So there's very different, it depends on your risk group. It depends on some of your anatomic features, what your quality of life with urination, sexual function, things like that are at baseline. And then there's other more complex things that come into play. Have you had prior surgeries? Do you have other things that might make radiation more difficult? Things like ulcerative colitis, Crohn's disease. So it gets very complicated. And so it's really best to kind of sit down with patients and really go through all of that stuff, not with just me, but also with urologists here, so that we can have that discussion. I think just in terms of some of the benefits of radiation that some patients more gravitate towards is that it doesn't require hospitalization. It doesn't require an invasive procedure. So patients, if they want to keep working during treatment, that's a way that they could consider doing it. That's not true for all radiation treatment options, because there are some where you have to take some time out of work or some time out of your life to some downtime for the treatment. And the treatments with radiation are more protracted. We can't, it's not a once and done thing like a surgery is a one care event and then a period of recovery. Radiation is, there's not a radiation treatment where we can deliver in one day. So the shortest we can deliver is in 1 week with 2 treatments like the brachytherapy that I mentioned earlier. But a lot of treatments are delivered over several weeks. So it's advantages or disadvantages as well. So I think really the best thing is, like I said earlier, is just to have a discussion with us, with all the members of the team, to really look at those options. And a lot of time, I can't imagine many times that I've really told a patient this is the best treatment. There's usually not one single best treatment.
Right.
So we leave it up to the patient to help them decide. And a lot of it is in education and us providing a lot of information, risks, benefits, side effects, logistics, so that it can help make that decision. And then ultimately the patient's driving the bus. I mean, we're here for them. So.
Yeah. Dr. Viterbo is a urologic oncologist. Do you have something to add to that? I mean, how do you view this?
Yeah, so I would echo exactly what Dr. Holman says. It's very complex. Sometimes the hardest thing to consider as a patient is that you have more than one option, right? It's easy when sometimes we can say, this is your best option, it's surgery. But prostate cancer, luckily, gives you some options and some time actually to think about what is in your best interest. And sometimes it's not so easy. Sometimes they'll come to the surgeon and I'll say, this is a good option for you, but so is radiation. And then how do you make up your mind? Some patients will consider what their family members have had. Unfortunately, we see prostate cancer sometimes in family members with a genetic predisposition. And sometimes what I'll tell patients is, if we consider everything and all things are equal, you as a patient need to kind of make a mental list of, here are my risks, here are my benefits. And it's a personal kind of approach. You know, what am I willing to risk? What am I willing to benefit? And the type of person you are. Surgery may be very definitive. You know, you remove the prostate. I know exactly what was in the prostate. That may be somewhat appealing to a patient. Or that the fact that they're in the hospital overnight, it's treated, they go home the next day, and it's not a long event. Or maybe just the risk of surgery is too much, you know, the anxiety of having surgery. And so there's a lot that goes in. Maybe the patient has some obstructive symptoms or difficulty with urination, may make him a better surgical candidate. So there's a lot of consideration in that. And as a urologist and as a radiation oncologist and a medical oncologist, sometimes it's our team approach, kind of, you know, making sure we present all of these things to our patients and help them in their journey. Sometimes that's where we come in. And the good thing about prostate cancer is you can really take your time. It's not something that you need to decide within days or even sometimes weeks. Sometimes you can take up to a year and consider active surveillance for lower risk prostate cancer, where we kind of watch and wait. So yeah, agree with Dr. Holman, gets complex, and having a meeting with one of us or sometimes all of us may help in that decision making.
Yeah, absolutely. Well, this is great. 2 points here. One, welcome to Dr. Anari. Dr. Anari is, as I mentioned earlier, one of our genitourinary medical oncologists. Welcome. And Dr. Viterbo, you brought up active surveillance, actually. That is one of the questions. Dr. Correa, is there anything new in regard to active surveillance, for low-risk prostate cancer? Are we doing active surveillance here at Fox Chase? Do we have a particular protocol? Any thoughts on that?
Yeah, thank you, Dan. No, I think active surveillance is a very important part of the management of patients with localized prostate cancer. And I think that the indications of active surveillance continue to expand as we are actually learning more about how this cancer behaves, especially people with low-risk disease, but even low-volume intermediate-risk disease are cancers that we can push the envelope and follow these patients with this very safe strategy. I think that that's the important thing for patients to understand. Active surveillance doesn't mean no treatment, is that we're just following your cancer very, very closely to make sure that at some point that your cancer does worsen, then we can take the risks and the quality of life effects of form of treatment and actually make sense with the kind of cancer you have. So I think active surveillance is probably what we most recommend for patients with low-risk disease. I think that we are cognizant of the fact that any treatment option that we offer does have an impact in patients' quality of life, and that's equally important as much as the cancer is for those patients. And so I think that active surveillance is an excellent strategy for patients with low-risk disease. In regards to active surveillance protocols, yes, we do have a standardized way that we do our active surveillance here at the Cancer Center, which combines the use of PSA, prostate biopsies, and imaging. As we alluded at the beginning, we have the micro-ultrasound, which is an added tool to our armamentarium for patients in the active surveillance sphere. So again, very, very important to be able to counsel patients to be in the sphere, because patients get told they have cancer and their emotional reactions that the cancer needs to be treated. And part of our job, as Mark talked about, is the fact that we have to be educators in patients' journey through their cancer and be able to tell them, hey, this cancer at this point is not aggressive enough for you to actually have to get this treated. And I think that decreasing that anxiety is probably one of the most gratifying parts of our job as a cancer doctor.
Yeah, great. Dr. Anari, one of the questions that came in is about androgen deprivation therapy. And, for those who are not familiar with it, that really usually means lowering a man's testosterone. And it's probably the most widely used systemic therapy, both by radiation oncologists, urologists, and medical oncologists treating prostate cancer when necessary. And unfortunately, that therapy, although quite effective, has a number of possible side effects. And one of the questions was about fatigue. And do we see that? Can it cause that? Is there anything to do about that? And, I would add to that, anything else that you counsel your patients about, Dr. Nari, when starting androgen deprivation therapy?
So I think fatigue is one of the common side effects that we see by lowering testosterone. I always tell men it's basically the male version of menopause. So you're taking testosterone that gives men energy, and you're lowering it on purpose to treat the prostate cancer, but it has a number of side effects. So when it comes to fatigue in particular, what I always counsel my patients is that the more active they are going into therapy, the more active they stay during therapy. In general, I find the better that they feel. So I don't place particular restrictions on really on anything, depending, obviously each person's a little bit different, but when asked, can they still go to the gym? Can they still go on their walks? I always say yes. I think it really is beneficial to keep active and stay active. I find the fatigue hits the worst when people are more sedentary. So really keeping up your normal routine as best you can is probably the best way to combat that. So that's how I really try to manage the fatigue, is staying as active as you can. And I always tell people, while it can cause fatigue, I do not expect that you should be laying in bed all day long. That I wouldn't expect from the androgen deprivation therapy alone. So if that's happening where you're really not yourself and sleeping the day away, that's something we need to address. And I don't want to wait until our next visit to see what's going on.
Right. And, this addresses one of the other questions, and I'll address this. There is a brand new preparation of hormone therapy called Orgovyx or Relugolix. It's actually a pill form of what used to be shots, generation antagonists like Firmagon. And it's brand new, FDA approved this year. And for those who are not aware, it lowers testosterone. One of the benefits is that it's a pill rather than a shot. Another benefit that was seen was in regards to a lower rate of cardiovascular side effects. And cardiovascular side effects are real and a real possibility with androgen deprivation therapy. And, you may hear about this. And one of the questions that came in is, what about using that pill, this Orgovyx, with Xtandi? And Xtandi, again, for those who are not familiar, is an androgen receptor inhibitor. It's been around now for some years, but it's one of the novel androgen receptor inhibitors. It's something that we use with metastatic disease, usually either hormone sensitive or hormone resistant. And the question is, can you use the two together? And I'll just answer that question and say that Probably you can, but there's actually not very much data at all in combining the two. This new pill, this new hormone pill, Orgovyx, was really studied by itself as hormone therapy alone. It has not really been combined in very many patients at all together with anything else. And although we would expect that it should be safe, the mechanism of action should be safe to combine with other hormonal therapy, we don't know for sure. So you really have to be careful. And I think this is sort of an individual discussion. There may be reasons why you'd want to do that, but you really need to talk this through with your physician. Okay. Let me ask another specific question. A question came in about, is the micro-ultrasound that we mentioned as good as MRI imaging? So when you're trying to do either biopsies, you're trying to do surgical planning, this is either for Dr. Viterbo or Dr. Correa, are they as good or not really?
I think that the data has shown that there's been no randomized, there's been no trial comparing both of them in a randomized setting, but the data coming out shows that they're equivalent and they're complementary. So what happens is that there are lesions that the MRI picks up that the micro-ultrasound doesn't, and there are lesions that the micro-ultrasound picks up that the MRI misses. I can tell you that the anterior zone or the top part of the prostate is better imaged with the MRI versus the micro-ultrasound, but I think that in our experience so far, I think the micro-ultrasound has helped tremendously, at least detecting patients that have these negative MRIs but seem to be having a rise in PSA, and we really can't explain why. And so having that added modality either finds a lesion or gives the patient peace of mind that there's nothing there that could just be causing some mysterious tumor that is being missed. Because we all know that MRI is good, but it does miss 25% of the lesions. So again, micro-ultrasound does allow us to be able to offer patients an added imaging tool for those that have those situations.
Great. Dr. Wong, we do not offer proton therapy at Fox Chase. Could you speak a little bit about proton therapy and how it compares to what we offer, and pros, cons, as folks are making these kind of decisions?
Sure. I think that's a great question, and it's one I hear often when new patients are coming in. There's a lot of advertising and a lot of kind of popular culture around this, but sometimes there's a little bit less about the nuts and bolts about what the difference is. At Fox Chase, we offer intensity modulated radiation therapy, which is the most modern way of delivering radiation therapy, which uses both modern treatment planning techniques as well as modern image guidance to be able to be as accurate and safe as we possibly can with delivering radiation therapy. Typically, that is delivered with an X-ray, which is just the particle that, or the method with which the radiation is delivered to the patient. Proton therapy is the same basic plan, but it's delivered with a particle, which is a proton, instead of an X-ray. The machines are very similar. The experience of getting the treatment is very similar. A lot of the basics are very similar between them. And proton therapy can have benefits in certain situations. Protons have stopping power, so that a beam can stop within the body without passing through. However, that is generally most useful when you're only treating in one direction. So if you're only treating in one way and trying to avoid something right behind, and generally that's not the case with prostate cancer. That typically with prostate cancer, that the prostate sits in the middle of the pelvis. There are normal tissues in front and in back, as well as hips on both sides. So there's not really one direction you can come in and be more safe with. And so we can take advantage of X-rays and their properties, as well as all of these modern techniques that we've developed for X-rays to be able to minimize that radiation dose to normal tissues and to be as safe and accurate as possible. Not all of that has been developed for proton therapy yet, so there certainly is a lot that can be coming up in the pipeline, but for now, a lot of that is not quite there. Both are good ways of treating, and I think anyone that's interested in hearing about both should definitely get a consult with someone who can go over the nuts and bolts about what the differences are and what might be best for each scenario. But in general, they are much more similar than they are different.
Yeah, thank you. And I do think that's a very common question, and that patients ask. So important to do the research and find out what you're comfortable with. I want to address there's a few questions that are surrounding PSMA that have come in. One about sort of using PSMA for imaging, and I think I'll piggyback on that and talk about a little bit PSMA for treatment. So I think we're all obviously familiar about PSA. PSMA is another protein that is overexpressed on prostate cancer cells. And what folks have been doing, and the new technologies that are coming out, are using that, leveraging that to both diagnose prostate cancer and also treat prostate cancer. And so we're all familiar with CAT scans, we're all familiar with bone scans. There are now PSMA PET scans that are actually FDA approved, not quite widely available yet, that are much more sensitive at detecting prostate cancer throughout the body than, for example, a CAT scan would be, or a regular PET scan or a bone scan would be. And it's actually quite revolutionary in our field because all of our trials, all of our work has been done using what we call conventional imaging, bone scans and CAT scans. And what we're seeing now with these PSMA PET scans is they're picking things up that we never knew about. And how to change recommendations for various treatments, be it localized treatment or systemic treatment, is really complicated. And nobody actually knows the answer to that yet. And it's a work in progress. And somebody asked, is it available here at Fox Chase? And the answer is not yet. It is FDA approved, but there's actually only a few centers in the whole country where it's available outside of clinical trials. And the reason has to do really with the production of the agent itself, that is just very difficult to do, and few sites can do that. We expect it's going to become more commercialized and easy to offer to everybody soon, but it's not quite yet available here at Fox Chase. On the flip side, there are now actually therapeutic agents that are targeting PSMA. So you can imagine, just like you can use this to image the cancer cells, you can actually target molecules and payloads, what we call drugs, radiopharmaceuticals, to PSMA expressing prostate cancer cells. And there have been work now presented over the last year really showing great success with this. There's actually going to be a presentation regarding this just at the end of the month at our annual meeting. And these are technologies that are sort of coming up and will, I'm sure, be FDA approved sometime soon. We actually are about to open a clinical trial with one of these agents together with a hormonal agent or by itself. And so it's definitely a promising drug for men with advanced prostate cancer, and something that I think we'd be happy to talk to folks about. Let me ask a question now to Dr. Viterbo. It may sort of, not sure, necessarily relate to prostate cancer, but certainly can. And it's an important question, which is that you get a PSA and it's elevated. Can that simply be a result of an enlarged prostate gland? Does it always mean that it's prostate cancer? How do you deal with that? Does every elevated PSA need a biopsy? Should you always see a urologist for an elevated PSA? And sort of, what's your thought process on that?
That's actually a great question. And we certainly see a large amount of patients with elevated PSA. As we know, a PSA is a protein that is made in our body, and all men have PSAs, not women. And it's not a prostate cancer marker per se that, if it's elevated, just means that this protein is being secreted in higher levels in your body. So people who have an elevated PSA don't necessarily have prostate cancer. It may be a function of a larger prostate. So the bigger your prostate, you may have a larger number. And so it's important to reflect on what is your trend of PSA. Some patients who have inflammation may have what we call more leaky cells or a leaky prostate. So they may seep out a bigger PSA protein. So their PSA may be elevated for that reason. Or if they have certain gastrointestinal issues, or who've had any type of instrumentation past the prostate, if you've had a Foley catheter placed for a recent surgical event, or if you've had the flu, or any type of stressful situation where your body is kind of, going on overload, your PSA may be elevated. And sometimes just repeating it after an event, or urinary tract infection, for example, you'll find your PSA will go back to a normal level. You don't always have to see a urologist for an elevated PSA, but certainly you can, especially if you need reassurance. Sometimes we can reassure you that this is not an issue. Sometimes an elevated PSA does require a biopsy. Usually sometimes depending on how high it's elevated, or if it's consistently elevated above what your normal PSA range is, then we may say, let's try and get some imaging before we do a biopsy. We certainly want to try and do the least invasive things first. And then if we find that PSA is consistently elevated, or we're not happy with the number, depending on your age or, your medical situation, then we may get an exact view ultrasound, which, we can do in our office easily, and may not require any insurance approval at all. Or we get an MRI to better look at the anatomy maybe of your prostate. How big is your prostate? Is there any type of obstructive pattern that we see? Or is there a lesion there that we see that we may be able to target later on in a biopsy? So certainly an elevated PSA does not mean you have prostate cancer, but it does warrant more investigation. And sometimes it's just a reassurance that this is okay. And sometimes it may warrant more investigation, imaging, or biopsy.
Great. Yeah. It's certainly complex, and I think it requires discussion. I think what we're hearing from everybody here is, I think, communication, discussion, availability of physicians and support staff. Everybody is really critical to this whole journey, really. So that's great. Holly, speaking of anxiety, I find, anxiety is very, very common throughout the whole continuum, really, with diagnosis, with treatment, with change of treatment, with side effects. Do you see that? How do you counsel patients? How do you counsel family members about that? Are there services that we have that may be helpful?
Sure. So yes, anxiety is one of the big things that we see as far as emotional reaction to certainly a cancer diagnosis. I mean, people hear cancer and almost always think the worst. And so that triggers anxiety in and of itself. Surgery for most people is an anxiety trigger as well. I always tell the gentleman that I'm working with before surgery that if you weren't a little bit anxious, I would actually be more concerned than I am the fact that you are anxious. It shows that you are human and that you are still feeling things, which is important. As far as dealing with anxiety, I try and work very closely with patients and family members to get to know them a little bit, get to know the triggers that set off anxiety for them and what are the things that they actually feel. Some patients will feel difficulty concentrating. Some patients will feel a rapid heartbeat or actual palpitations. Some people can't sleep. And so I try my best to tailor interventions accordingly. But some of the things that I like and use a lot are journaling to try and help keep track of the thoughts that sometimes we're not always paying attention to, so that we can then address those worries and concerns up front. Progressive relaxation is something that I really like to use for people, particularly who are having difficulty sleeping. It's a way of sort of starting at either end of your body and working your way down, relaxing every part of you. And in doing so, it sort of takes your mind off of the things that you're worrying about, because you have to focus on tensing and relaxing each body part. That tends to be very helpful for people who are having difficulty sleeping. Sometimes, unfortunately, there are people who are just wired for anxiety. And in those instances, we like to get psychiatry involved to see if some of the antidepressants or anti-anxiety medications might be of help. The other thing I notice in prostate cancer patients, particularly men who are on hormone therapy, is depression, and that is something that we really, as all of us as practitioners, want to know about, because it is a quality of life issue that can be relatively easily dealt with, and is common. Nobody needs to be ashamed of.
Yeah, absolutely. And I think speaking openly about this is something we encourage, all of us do, because there's actually things we can do about it. It's not something you just have to kind of suffer with. And we encourage everybody really to talk about it. We don't have a lot of time, but I want to get a few more questions in, if that's okay. Dr. Holman, you mentioned when you talked about using some technology for high-risk patients, and I wonder, is that something that you can also offer to the low-risk prostate cancer patients? And I'm not sure if that maybe has something to do with the spacer or some other technology, but sort of how do you differentiate sort of the low-risk versus the high-risk patients in terms of what you can offer?
Well, so that's usually based upon kind of three of the major risk features that we look at. How high is the patient's PSA? We look at the biopsy. What we're looking for there is a Gleason score. How high is that? Higher Gleason scores can get you into the high risk range. And then other things that we look at are the tumor stage. If it's a locally advanced tumor, that's a high risk feature. Kind of tailor treatments based upon that. The brachytherapy can be used in different phases of treatment. Like I said earlier, when we were talking about that technology, that can be used for all different phases, but it's not right for everybody. There's something else, some of the other newer technologies that we're using in radiation therapy, which is commonly used more with external beam radiation therapy, but we're starting to use that with our brachytherapy treatments, is a technology called spacer. And it's a gel that's injected actually by our urologists. Very similar. It's done very similar to the way we do the biopsies, the way we do the brachytherapy. It's done under ultrasound guidance. A small needle goes through the skin, and they inject this gel that pushes the prostate away from the rectum. The rectum's one of the areas where we're really trying to avoid how much radiation is delivered, because it decreases side effects, and less radiation is less side effects. So we want the radiation to deliver to the prostate, but not to the rectum. The difficulty classically has been that the prostate is so close to the rectum, right? It basically touches. And so this gel is this nice technology that once it's injected makes all this space. You have a couple millimeters of space or less now is, basically with 13 millimeters on average. It's about half an inch or so, 3/4 of an inch, which doesn't sound like a lot, right? This much to this much. But in terms of radiation oncology, when radiation therapy, when you're talking about millimeters, that's a huge amount, because we work in millimeters. We're so precise, and our technologies in imaging delivery is so precise that millimeters really matter. So that can really decrease how much radiation is received by the rectum. And in a lot of cases, that will decrease side effects. The radiation treatments that we use already have decreased those side effects. Some of those are brachytherapy, some of those are imaging and image guidance, intensely modulated radiation therapy, stereotactic body radiation therapy, just focusing the radiation. This is another tool in the armamentarium that helps. And so that's kind of one of the newer things that we're offering and studying here at Fox Chase. Yeah, that's great. So time flies, and it's 7:31, and I want to be conscious of that. I want to also mention, sometimes we don't talk about it, but a question came in about sexual function and sexuality, and I think this is very important. And I think, people are a little embarrassed sometimes to talk about it, but shouldn't. A lot of the therapies that we talked about today, unfortunately, have an effect on sexual function. We actually have an erectile dysfunction clinic here, and really proactively refer men, after surgery, while on hormone therapy, whatever, to see actually Marcel, who is really an expert here and works with us, and to help with that. So I want to bring that up, because I want to encourage everybody on, if that's an issue, to discuss that with your providers, whoever that may be, because again, just like with depression, just like with anxiety, potentially there's something that we can really do and help. I think with that, this is our time. I really appreciate everybody coming on, and Holly and Mark and Karen and Andres and Leah and Fern and Trish
Yeah, thank you for being here. Everybody who's on and submitted questions, thank you. We'll try to answer any that we couldn't get to. We are going to try to do this again in the fall. I hope this can be in person at some point, maybe in the fall. And, I think, again, if you have any questions, please feel free to reach out. Thank you to our exhibitors and our supporters, and be safe. Thank you very much.